I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. MedEd 101's Nursing Pharmacology Review course is built to make meds finally click. You'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed by pharmacology experts for nurses. Stop memorizing, start understanding pharmacology at meded101.com/nurse. In this section, I'm going to cover the basics of HIV infection. So first off, what is HIV? It is human immunodeficiency virus, so it's a viral infection. It attacks the immune system. So, the name kind of says it a little bit there. Specifically, the important part or piece of the immune system are CD4 T cells. Okay, so these play a critical role in the functioning of the immune system, and the virus attacks these cells. Ultimately, if untreated, HIV progresses over time, usually the course of years, to weaken the immune system. And what happens is patients end up dying from opportunistic infections or certain cancers, again, if left untreated. HIV is transmitted through blood, sexual contact, potentially during pregnancy, birth, or breastfeeding. Without treatment, HIV can eventually progress to what's classified as AIDS, acquired immunodeficiency syndrome. And this is, ultimately the most severe stage of infection, where we start seeing some of those opportunistic infections or cancers show up. All right, important nurse monitoring, just from a big, broad overview here to start. So CD4 count, I think that should probably make sense based upon me describing HIV. Viral load is something we also monitor. Signs of opportunistic infections, any type of fever, cough, those type of things, super important as a nurse monitoring an HIV patient to pay attention to. Adherence to antiretroviral therapy, that's the term used for medications used to manage HIV. Adherence is so important. There is a significant risk for drug resistance, especially if we are taking medication sporadically. Okay, important thing there. Adverse effects, we'll get into all the different classes and things, so pay attention to that. Psychosocial status, I think that kind of makes sense. Support system, many of these patients can feel isolated with their disease, and then certainly those at-risk behaviors and the potential for spreading HIV further. Vaccination and infection prevention are going to be important. Remember, these patients, over time or as the disease progresses, may be more at risk for certain infections. All right, so drug resistance, I alluded to, that's going to be critical when it comes to talking about pharmacology and medication management. Immune deficiency, we may have to treat opportunistic infections with medications or potentially try to prevent them. Monitoring, CD4, RNA, those I alluded to already. All right, medications and medication classes, let's get into them. So, first off, I'll start with the mechanisms and how these medications work. So first, we've got the NRTIs, so nucleotide reverse transcriptase inhibitors. Mechanistically, these drugs get converted to active triphosphate forms, which competes with natural substrates to inhibit reverse transcriptase. The HIV virus this enzyme uses reverse transcriptase to convert RNA into DNA. And if we inhibit that enzyme, we can prevent that process and further replication of the virus. Unfortunately, these drugs are not 100% curative. We can't, haven't found a way to get rid of the virus totally, but they do provide a good option there. Lamivudine and emtricitabine are the two most common medications used in practice that I've seen. Integrase inhibitors, we've got a few of those. These drugs inhibit the viral enzyme integrase, and it does this by binding enzyme cations and preventing viral DNA integration into the host genome. Okay, so integrase inhibitors, we're inhibiting that enzyme integrase. Non-nucleotide reverse transcriptase inhibitors. These do not require active conversion to triphosphate forms like the NRTIs. They actually bind to what's called a hydrophobic, so it's a kind of a lipid-loving site, opposite of hydrophobic, so water-scared. So it's a more lipophilic type site, fatty type site of the HIV reverse transcriptase, and ultimately inactivates it that way. Protease inhibitors, mechanistically, these bind to the site where protein cleavage occurs and prevents protease from releasing essential proteins that the virus needs to grow and replicate. CCR5 inhibitors, I'm not going to spend a ton of time on those. Fusion inhibitors, they are potential options, but definitely not used as commonly. All right, NRTIs. So tenofovir, very commonly used medication. Adverse effect profile, osteoporosis risk, and renal toxicity. Those are two definitely to remember. Lactic acidosis and fatty liver boxed warning. Very important to remember that as well. Now, the big difference between TDF and TAF is the renal risk and the osteoporosis risk. It is lower with TAF or TAF. Okay, so that form of tenofovir tends to be a little bit safer in that regard. Other agents, bacavir, emtricitabine, lamivudine of the NRTI variety. Bacavir, it's important to note, we actually have genetic testing. Okay, so HLA-B 5701, we must screen for this prior to giving the medication. Okay, so if a patient tests positive, they are at increased risk for a hypersensitivity reaction. Okay, so definitely one to pay attention to. If you see a bacavir, make sure that testing is done. Emtricitabine, lactic acidosis, fatty liver risk exists with that medication as well as lamivudine. Hyperpigmentation, that's a darkening color, is an interesting adverse effect there. Integrase inhibitors, some mild to moderate elevations in LFTs is possible. Skin reactions, SJS, rare but possible. Psychiatric changes, CNS changes are possible here as well. CPK increase / myopathy, muscle soreness is possible too. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse. Common starting regimen. I mentioned a few of those medications already. There are other agents available, like in a long-acting formulation. Most of the drugs we have are oral, but this is an example of a newer, longer-acting agent where we don't have to give an oral pill every day. Also, many medications come in combinations, so we don't have 3 different pills. We can have 1 pill and have 3 different meds in them. So there are multiple combinations which can help increase and improve adherence, just like this agent is designed to do. Other medications, so NNRTIs, efavirenz, delavridine, a couple ones to mention there. This class has a unique adverse effect in that they can cause some significant psychiatric changes, hallucinations, abnormal dreams, things like that. Hepatotoxicity is something to remember as well with these, in addition to lowering seizure threshold. Protease inhibitors, best thing to remember here probably is they are notorious for drug interactions. Okay, definitely a good thing to remember there. Lipodystrophy, so this is kind of the buffalo hump, kind of on the shoulders, back of the neck. Those type of symptoms can happen as an adverse effect. Elevation in blood sugar, so pay attention with diabetes patients. We can bump those blood sugars up a little bit. Ritonavir in this class of medication is actually what's called an enzymatic booster. So we actually intentionally inhibit an enzyme that breaks down another medication to increase the concentrations of that other medication. So that's kind of a unique one there for sure. CCR5 inhibitors as well as fusion inhibitors, not commonly used. Adverse effects and a few clinical pearls are listed there. I'm not going to go into great depth there. Opportunistic infections, PCP pneumonia. This is one that always seems to come up, at least in my experience, on board exams and pharmacology exams. PCP pneumonia, pneumocystis pneumonia, common opportunistic infection. Drug of choice is Bactrim, so that's sulfamethoxazole trimethoprim combination. There are other options if that doesn't work. You may see glucocorticoids used as well to help with some of the symptoms associated there. Kaposi's sarcoma, another opportunistic concern here. This is a type of cancer, and chemoradiation is what we're going to have to utilize there. Mycobacterium avian complex, another potential infection. Macrolide antibiotic usually leads the treatment regimen there, such as azithromycin. Others you may see, cytomegalovirus, we may use some antiviral meds there. Tuberculosis, that's kind of a chronic low-grade infection for most patients, but in our immunosuppressed patients, TB can be really, really nasty for sure. Lead to chronic cough and weight loss and those type of things. Candidiasis, fungal infection, fluconazole, treatment of choice there. Toxoplasmosis. Cryptococcus being a fungal infection too as well. So we've got some meds there. If you go back to the fungal infection section, you can dig a little deeper on those meds. And then those lab values, RNA viral load, we have certain goals for that. CD4 count, we'd obviously like them to be in the normal range there as well. If we have a low CD4 count, if less than 200, for example, we may start doing prophylaxis for opportunistic infections, okay? So PCP and MAC prophylaxis, that's often initiated based upon the CD4 count and if that drops, because obviously if that gets lower and lower and lower, that's indicative of an immune system that's probably not ready to fight back against bacteria and other infections. All right, a couple things I wanted to mention is PrEP and PEP. So PrEP is pre-exposure prophylaxis. So this is indicated for patients who are HIV negative, so they don't have HIV, but they are at risk of developing HIV. So sexual partners of HIV-infected patients. That is probably the most common situation of patients who are obviously significantly at risk of contracting HIV and potentially should be protected with prophylaxis. Other patients, high-risk behaviors, multiple partners, sexual activity, IV drug users who share needles. This is transmitted through sexual contact and blood primarily are two of the big ways it's transmitted. Extremely low risk of transmission in patients who are adherent to HIV therapy. Highest risk of transmission is in patients who have a detectable amount of virus. So that's really why we want to keep that viral load low, in addition to the disease progressing itself as well. Medications that can be utilized here in this setting, tenofovir and emtricitabine. Another potential option is cabotegravir. This is an injection every 2 months. And then we've got post-exposure prophylaxis. So initiate PEP or post-exposure prophylaxis for patients who have been exposed through needle stick or other means of puncturing the skin or has been working with a high-risk patient. So somebody who has HIV, classic example being a caretaker, caregiver, nurse, aide, those type of folks. And there's a needle stick, contamination or risk there that happens. So definitely recommended to give post-exposure prophylaxis. Should be considered if a caregiver has an open sore or other non-intact skin, and it has been exposed to blood from a patient at risk for HIV. Drug therapy should be offered even before HIV testing has been completed if the source of that blood is not known. Okay? So again, ASAP as soon as possible, get that drug initiation going if there is potential for HIV risk. May offer post-exposure prophylaxis for up to 72 hours after exposure. Tenofovir and emtricitabine and an integrase inhibitor is recommended. We can substitute a protease inhibitor for integrase inhibitor if we can't use that for some reason. I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course.